So I think we will start. I hope you can hear me well. Good morning, good afternoon, and good evening. It's a great pleasure to have you here. Thank you very much for your interest. A very warm welcome. I'm just waiting for the slides to come up. So this session is on capacity strengthening for strategic purchasing. It's jointly organized by ThinkWell, the World Health Organization, and Spark. We want to look at what is needed to strengthen capacity for strategic purchasing and also share some good practice country examples on what and how countries have actually been doing so. I have the pleasure to introduce you to this session. My name is Nkechi. I'm a senior health financing specialist working at the Department of Health Systems Governance and Financing at the World Health Organization in Geneva, Switzerland. And I'm leading the work on the global work on strategic purchasing in the health financing team. The next slide, please. So let me give you a quick overview about these 2-hour sessions and the objectives, what we have in mind. After a brief introductory presentation from my side and some polling to hear from you about your country's situation, we will go into part 1, which is on identifying progress towards strategic purchasing in sub-Saharan Africa and understanding the drivers. This part will provide you with an overview of the functional capacities needed to drive progress towards strategic purchasing, illustrated by country examples. And we have very distinguished speakers from different organizations, and they will be presented later. And then the second part of today's session is on the tailoring of purchasing for high priority health interventions, and we will look at the example of reproductive health. Now, this is about looking into the specifics of such high priority interventions and look at what implies this for purchasing. Again, we have a really great panel of experts that will be presented when we come to that session. And we will finish with a final round of reflections, next steps, and also look into a potential future research agenda. I just wanted to mention that on your on-air platform, on the very right-hand side, you have this live Q&A function where you can put in questions throughout, but especially as we come to the discussion. So now let me move on and I'll provide a brief introduction into the subject. The next one, please. Really looking, sorry, one back. What is strategic purchasing and what is it not? To many of you, this will not necessarily be new, but the idea is really to clarify and to highlight a few critical issues. Next, please. So what is purchasing? Purchasing is one of the key health financing functions, revenue raising, pooling, and then purchasing. Purchasing is basically the allocation of pooled funds from purchases to healthcare providers on behalf of the population for the provision of health services. Now, in many countries, the most important purchasing actor is actually the Ministry of Health, of course, through its health budget, even though it may not be seen so explicitly as a purchasing actor or as the key purchasing actor. Subnational authorities like local governments can also be purchasing actors, as well as a mandatory national health insurance, and I've listed here other purchasing actors. Next one, please. Sometimes, in fact, purchasing is mixed up with procurement, but it's very important to actually clarify that the two are different. They are related, but they are not the same. So purchasing, or in French, l'achat, relates to the allocation of funds for health services. So I really put the focus on health services. So the purchaser, as I have just listed, Ministry of Health or others, are basically allocating funds or paying the service providers. And we will go into the actual elements of purchasing, such as the payment methods and the contracting later, and also especially in the next section. In contrast, procurement is about buying goods and supplies in bulk. So in French, approvisionnement. The agency could be a central procurement agency, could also be a large hospital, or in some countries, in fact, even a purchasing agency may also engage in procurement activities, while at the same time they also purchase health services. So procurement would involve activities such as determining the volume and type of goods to buy. So for example, what medicines to buy and what volume, then selecting the vendors, negotiating the prices. Next one, please. So then the question is, what is strategic purchasing? Strategic purchasing means and implies that the decisions on the fund allocations are based on information on the performance of providers and also on information regarding the health needs of the population served. When I use the term performance here, I mean it in a rather generic way, and I'm not referring to the specific meaning in performance-based financing. So in contrast to passive purchasing, strategic purchasing is an active, evidence-based process. It's evidence-based because you need information, you need to generate and use that information in order to define, ideally, which specific health services should be bought from which providers, so what provider type or at what level of providers, and thirdly, how the services, the health services should be paid for and at what rate. Next one, please. So here you see an overview or a summary of the key elements and the key policy questions related to strategic purchasing. In the middle, you see the three core elements of, and they're overlapping because they're interrelated, the three key elements of what to buy, from whom to buy, and how to pay. And that is embedded in two larger circles. These are other two key elements of purchasing, namely the management of information management systems, as well as the governance arrangements for strategic purchasing. And in the next presentation, we will go into much more details about these functional capacities and elements of strategic purchasing. Next slide, please. I want to come back to the issue of passive versus strategic purchasing. Some of you may have seen this slide. We have been using it a lot. It's a quite old slide, but I think it's quite useful, and it's important to realize that passive versus strategic purchasing is not something black or white or all or nothing or yes or no. It's really a continuum. In fact, it's a road, and that road can be quite bumpy. It has hurdles. I've tried to actually indicate this with this line here. It's not a very nice line. It's not a perfect line, but that's precisely what that process is. It's not so easy. It's not so straightforward. But what we have to keep in mind is that all countries at all income levels are seeking continuously to progress on this spectrum towards more strategic purchasing. Some countries are more still to the left, more towards passive purchasing. A lot of countries may be somewhere in the middle. Other countries are more to the right. It also should be kept in mind that not every purchasing reform actually leads automatically to more strategic purchasing. Sometimes it can sort of put you back if it's not the right purchasing reform. But ultimately, the idea is that this is a process that continues. There isn't really an endpoint. It's really about continuously trying to increase efficiency, equity, and quality. Next slide, please. We also wanted to briefly go into this subject and have therefore included the slide in order to clarify and emphasize that performance-based financing is not the same and cannot be equated with strategic purchasing. At the start, performance-based financing is a payment method. It's an add-on payment in combination with and on top of a base payment, let's say a budget allocation or capitation. The interesting thing about PBF is that, as other purchasing reforms as well, that it comes with other institutional changes, so separation of functions, a rigid and solid verification process, monitoring. Facilities would usually or often actually get discretion space about the funds that they receive through the PBF payments. And so what we can say is that in many countries, specifically when there has been rigid line item budgeting allocations in place, the PBF has been an important entry point or trigger to move towards more strategic purchasing. For example, by giving pronounced financial incentives to the providers, by defining targets on provider performance with respect to quantity or quality, and also by giving incentives to generate data on provider activity. So PBF, in a way, can be seen as one element or as one reform example towards more strategic purchasing. A lot could be said now on this relation, but I'll just leave it at this point and I come to my final slide. Next, please. So why is there actually renewed attention towards strategic purchasing. For sure, purchasing is a function, it always has been there. The concept of strategic purchasing is nothing new. I mean, it's quite old, in fact, but yes, we do see renewed attention, and also from ourselves, we put more attention on it. First, I think there has been increasing recognition that strategic purchasing is critical for progress towards universal health coverage. You can't spend your way to UHC. Just raising more revenue will not help. Second, it has been argued, and country experience actually shows that sequencing of health financing reforms is very important. So if one starts with coverage extension through improving purchasing and benefits, you actually sort of grade and build the foundations, and then can engage in further pooling and revenue raising reforms. Another reason for it getting more attention is that purchasing became more visible and explicit when countries introduced a separate health coverage scheme or a separate purchasing agency, let's say a health insurance scheme. And finally, public financial management aspects are closely related with purchasing and vice versa. And as PFM has gotten renewed attention, it's also actually giving more attention again to purchasing, namely the need for improved budget formulation to reflect people's health needs, and also the need for a higher budget execution. With that, I will stop. Thank you very much. Next one. And before we continue, I just want us to now go into the on-air polling section, which is here on the middle on the right-hand side, and I will actually open those polling questions and I'll read them out. We have a couple of questions, as we like to hear about your purchasing situation in your countries. We have 3 short questions. The first one is, on a scale from 1 to 7, how strategic do you consider the purchasing in your country? 1 being rather very passive, 7 being very strategic. So think of this continuum, and I'll just give a few seconds as this moves on. Okay, so please enter. Okay. All right. As this goes on, I'll just read out the second question. Now, what type of purchasing agency is in place in your country? Is it a purchasing agency separate from the Ministry of Health or local government? So, for example, a National Health Insurance Agency? Is it a specific department or unit within the Ministry of Health? Or is it actually that there's no specific purchasing institution in place with an explicit mandate for purchasing? So let's just go back to the first question. We have a couple of votes. I would actually encourage more people still coming in to vote. We have, maybe as expected, several ones, the majority so far voting in the middle. So yes, you know, some reforms undertaken to move towards more strategic purchasing. And then a few sort of on the right hand and on the left hand side. So no strategic purchasing, more passive, others a bit more advanced. Okay, very interesting. Let's move on to the second question. What type of purchasing agency? So majority of the participants or countries that you represent, nearly half have a separate purchasing agency, and about a third of participants or countries have no specific purchasing institution with no explicit mandate. Okay, very interesting. And let me start and open the third question. Which aspect of purchasing works well in your country? Is it that benefits are well defined and clear? You can have actually multiple choices, as you see here. Payment methods are well aligned with each other and set coherent incentives to health providers. There are clear contracts between purchasers providers. Information is used on provider performance or people needs. Governance arrangements are effectively in place to coordinate, or none of this. Okay, so voting is going on here. Let's just wait a few seconds. Okay. So it's still going on, yeah, a few more seconds. But what we can see is that about a third of participants say that there are clear contracts in their countries, clear contracts between purchasers and providers. About a quarter have benefits that are well-defined and clear. A sixth of participants say none of this is in place. And information provision also, well, 15%. It's changing. Anyway, it gives, I think the picture more or less stays the same. The contracts are in place, very little on payment methods, little on information, a bit on governance. Okay, that's very interesting. I think that's also important to keep in mind for the next part of the session, to which I now want to move on. Let me actually introduce the facilitator and first speaker for that next part. That's Dr. Nkechi Olaleri. She is the Executive Director of SPARC, of the Strategic Purchasing African Resource Center, where she is steering its vision and empowering countries with knowledge and practical tools to make access to affordable and quality healthcare a reality for all. Nkechi is deeply passionate about strategic purchasing. She has broad knowledge and experience in supporting major health system reforms in the private and development sectors. And Nkechi will present the other speakers as well. And at this point, I will also already introduce the first speaker and facilitator of the second part. That's Dr. Nimala Ravi Shankar. She's a health system specialist with more than 15 years of experience working in Africa, Asia, and Latin America. She leads ThinkWell's strategic purchasing for primary healthcare project that is supported by the Bill and Melinda Gates Foundation. And she works with country governments to strengthen purchasing arrangements for primary healthcare services with a focus on family planning and MNCH services. Nimala has a PhD in political science from Harvard University. And with that, I hand over to Nkechi. Over.
Great. Thank you so much, Inka. That was a great intro to this conversation. And hello, everyone. So in the next few minutes, my colleague and I are going to walk you through the results of the strategic purchasing functional capacity mapping that we carried out at SPARC. But first things first, what is SPARC? SPARC is Strategic Purchasing Africa Research Center. Seems to be having some problems moving my slides, but we will fix that as we go along. And so SPARC is Strategic Purchasing Africa Research Center, and we are a hub in sub-Saharan Africa with the mandate to provide information, data, capacity development for strategic purchasing as our way of supporting countries as they make all of those very important decisions and spend very limited health budgets on their journeys towards universal health coverage. And so I'm going to try to describe how we do this using 3 action words. So connect, match, and share. And so what do we do in terms of connection? At SPARC, we work through our linkages and partnerships with different organizations, whether they're NGOs or government institutions or other academic institutions on the continent who are already working on strategic purchasing interventions on the continent. We work with these organizations to elevate the visibility of strategic purchasing and also to make sure that strategic purchasing becomes a key discourse in key policy discussions. But then we don't only work with these agencies, with these organizations, we also work with individuals. And then what do? We link up, we leverage, and we work with existing expertise within the continent that already exists in the continent to ensure that we're using the capacity that already exists in moving conversations on strategic purchasing forward. And then what do? We match them with country needs and with country demands and ensure that it's a perfect marriage of the right skill set and the right country demand as we move these conversations forward. And then the final thing that we do is then that we share. How do we share? We connect all of these experts together, one to the other, for peer learning, for experience sharing. And so with that, we ensure that all of the lessons that we're getting from the work that we're doing in strategic purchasing on the continent gets translated into information that can be used to help to clarify, to help to further provide visibility on how to do this work better and better. And while we do this, we use that same platform to ensure that we also provide access to coaching and mentoring support. And that's because we have come to understand that the work that we do in health systems strengthening is inherently political. And therefore, apart from the fact that we provide support for the technical parts of this work, we also provide the additional complementary non-technical skills that these experts need to be able to navigate all of those political economies that are part of the work that we do. And finally, we also provide access to global evidence to also help to strengthen the research, information and the expertise that we already have. I really am having problems trying to move my slides. I'm going to try to see if I can stop sharing so that I can start all over again. And so, but while I'm doing that, it's also then all of this work that we do is really predicated on our theory of change. And what does our theory of change say? Our theory of change clearly speaks to the fact that I don't seem to understand why I can't move. I'm not sure if there's any technical person to help with that.
Hi, Nkechi, this is Nimala. Do you want to see if maybe you have to select the PowerPoint window when you're moving? Does that
Yes,
help
I'm
at all?
doing that.
Oh, okay.
Just curious why this is. Just one quick second, I'll try that one more time and see. Okay. Perfect, finally.
Oh, fine.
All
Great.
right, so apologies everyone again for that. And so all of this great work that I talked about that we do at Spark is really predicated on our theory of change. And what does our theory of change say? It speaks to the fact that if we raise awareness of strategic purchasing and provide evidence on what works and in what situation, then policymakers will be motivated to make the necessary investments in strengthening strategic purchasing capacity, whether this is governance arrangements or whether this is strategic purchasing functions and policies, they will be motivated to make those investments. Now, if we have improved and strengthened strategic purchasing capacity, then potentially we will have better resource allocation. We will also have appropriate incentives all through the system, and we will have better accountability. Now, all of this can then be used as leverage by the purchaser that gets better health service delivery and better health system outcomes. And so from this description, you can see that our entry point into working on this theory of change is really global advocacy and evidence generation. Now, the focus on evidence generation is going to be what we're really going to talk to you about in the remaining slides, speaking to evidence that we generated from the mapping that we carried out in 9 African countries, the mapping of strategic purchasing functions in 9 African countries. We can't tell that story, of course, without telling you about our technical consortium. This is made up of 11 institutions, policy analysis institutions, academic institutions, think tanks, located across 10 different African countries, spanning Francophone and Anglophone Africa, and they work together on 9 African countries to produce some of the results that we're going to share with you in the next couple of slides. And so having said that, I now cede the floor to my colleague, Dr. Cheryl Cashin, Managing Director, Results for Development, and she will take us through the rest of the slides. Cheryl?
Thank you so much, Nkechi, and good morning, good afternoon, good evening, everyone. I want to very quickly share the analytical foundations of the country experience that you'll hear in the rest of our part of the session. Very early on in Spark's lifetime, it was agreed that there needed to be some common language about how to understand what countries were doing with strategic purchasing, and then to generate some lessons about what might be some drivers of progress, and also identify where there were some good opportunities to learn and where there were some priorities for support and to make more progress. So this was the thinking behind this mapping exercise, to get some baseline information for the countries to then learn from each other and make additional progress. Maybe the next slide, please. So the idea of this functional mapping exercise was to take the multiple conceptual frameworks that are out there for how to understand strategic purchasing and to try to put them together and translate them into some very practical concepts and practical building blocks that the countries could look at and describe in their systems. And so we looked at the conceptual frameworks that were generated by the RESIST network, by WHO's health financing progress matrices, and by the strategic purchasing progress mapping from USAID's health financing governance projects, kind of put them all together for the conceptual foundation, and then dug a bit deeper and tried to build out what are all of the functions that need to be in place for countries to make good decisions about what services to buy from which providers and how. And we looked at functions like financial management, benefit specification, contracting, provider payment, and monitoring, and what capacities need to be in place for those functions to get the results of better resource allocation, appropriate incentives, accountability, and then the ultimate outcomes that we are interested in, understanding that a lot of external factors will either enhance or mitigate the power of strategic purchasing. So this was the framework that we started with, and then translated that into a practical Excel-based tool for our partners to collect the information and describe what was happening in their countries in each of these functional areas and some of the policy decisions that were being made in these areas. In the next slide, please. So just say a couple of words about the process for this mapping exercise before I hand it back to Nkechi to share the remaining speakers and the country experience that came out of this. I don't know if we can get to the next slide. Okay, so the process that we undertook was to translate that framework into the Excel-based tool that then each of the countries went and engaged with the stakeholders in their countries to collect both quantitative information, desk review, and some qualitative stakeholder interviews to populate and get a picture of what was happening in each of these areas, identify some pockets of progress, try to understand what was driving that progress, and then how that might be linked to some of the outcomes that were being achieved from strategic purchasing in those countries. That process took about a year to complete in the 9 countries that have completed it, and then the group convened in Cotonou in February of 2020, before the global pandemic landed on all of us, and were able to share experience and to create a learning agenda out of the initial results of that capacity mapping. And we're going to hear some of the outcomes of the learnings in the rest of this session. With that, Nkechi, I'll pass it back to you to set up some of these high-level learnings and our 2 speakers. Nkechi, are you able to advance the slides?
We cannot hear you. Nkechi, maybe it's about the mic.
Ah, there she's back. Nkechi, we see your slides, but we don't hear you yet. Okay, we just heard a bit. Do you want to just say something again?
Seems there is a internet connection problem.
Right. So picking up from where Sharon left off, I hope you can all hear me, and I hope you can see my slides. Some of the drivers of benefit.
Looks like we lost Nkechi.
I wonder if we should move right into our speakers. Is there someone else who can put up the slides for Elizabeth and Obi?
Why don't you move ahead, maybe, Cheryl, with introducing the speakers as we get up the slides from your side, somebody?
Is there someone from the Spark team who can put up the slides for our speakers? Thank you, David. So we're going to move on now and hear some of the results that came out of this from two countries, from Uganda and Nigeria. And if we could move on to the next slide, please. I'd like to first introduce Dr. Elizabeth Ekirapa, who is going to share with us. She's a technical partner from Makerere University School of Public Health, and to share these results from Uganda. Elizabeth, over to you.
Okay. Thank you, Cheryl, for that introduction. I'm excited to be sharing with you some of the results from the strategic purchasing work that we did. We can move to the next slide. With regard to where we are with strategic purchasing in Uganda, like has been mentioned already, we as a country have a minimum package of services that targets the highest causes of disease within the country. Our public sector mainly purchases services from public providers and a set of private providers, while development partners tend to purchase services largely from the private sector. The country is slowly embracing strategic purchasing approaches, and the capacity for state and non-state institutions to implement strategic health purchasing has also been growing. However, we have limited domestic funding and some fragmentation in our funding pools, and this limits the benefits that we could get from strategic purchasing. In the next slide, I'm just sharing with you again some of the aspects of what we found looking at the different purchasing functions. With regard to benefit specification, like I mentioned, we have a minimum healthcare package that stipulates the services that we're interested in purchasing. And some priority groups have been targeted and have been able to receive the services that they need. However, we have patchy provision of these services largely because of limited resource availability. With regard to contracting, we have selected contracting of both public and private providers, and our facilities receive direct funding There are also incentives for providers in hard-to-reach areas within the public sector. However, we have limited sanctions for poor performance, especially in the public sector. When we looked at provider autonomy, the providers have guided autonomy, which we found is more suitable in a setting like ours where corruption is still a problem. However, the benefits that they can get from this guided autonomy is limited by the fact that the non-conditional funds that they get from government is very limited. And so they can do very little with the non-conditional funds that they have. However, the funds that they get from development partners usually have only minimal conditions. And so they're able to use these funds more flexibly, and they're able to use them to meet the needs of their local populations. With regard to payment and quality, payment has been linked to quality, particularly in the output-based projects that are often funded by development partners. We currently also have a new performance-based financing project that's being funded within the country that is also linking payment to the quality of services that is provided. However, the public funds are generally not linked to quality because it still has a large element of passive purchasing in it. Lastly, I'll just share two of the lessons that we have with regard to strategic purchasing. We found that the practice of zoning donors and harmonization of government and donor priorities has been able to lead to expanded nationwide coverage of targeted groups. The donors who provide reproductive health services and HIV services have been zoned such that they cover the different areas of the country. And when their priorities align with those of government, for example, with regard to HIV services, then you find that the development partners and government are ensuring that we have facilities in place, providers in place to provide services, and that is what has led to expanded coverage. For example, almost every pregnant woman can be able to access prevention of mother-to-child services because of that particular happening. With regard to autonomy, I mentioned that we have guided autonomy, and when this is coupled with improved work planning, direct facility funding, and provision of funds with minimal conditions, we have found that it also enables the facility to deliver quality services. Guided autonomy ensures that the facilities have some limits and some expectations of what they should spend the funds that they receive on. And when the facilities are able to identify local needs, local services that are required, then they ensure that the money that they receive is targeted towards providing the needs that the local people need. And so when they get direct facility funding that is flexible, then they are able to meet those particular needs and to provide the services that the local facilities need. But we have also found that for strategic purchasing to work well, sometimes it needs to link well with different procurement regulations in the country that sometimes put up obstacles in the way of allowing facilities to access funds within a short time or to use the funds to actually meet the needs that may be present in their local areas at that particular time. So there's some regulations and bureaucratic restrictions that make that difficult. And so the procurement regulations need to be reviewed so that they can match well with the needs and be able to be used to meet the needs optimally. Thank you. Those are the experiences that I'd like to share in the time that we have.
Thank you very much, Elizabeth. I think that this experience really highlights some of the importance of the external factors that we have been trying to look at in our framework. And you mentioned three really critical ones. And the first one is harmonization. When there's too much fragmentation among purchasers or between government purchasing and donors, that really weakens the power of purchasing. And same with autonomy. If providers don't have the autonomy to respond to new incentives in the system or new signals in the system, then purchasing won't be effective. And then the third external factor that you highlighted that really comes up in all the countries, and that is the need to align public financial management, procurement, and other regulations with new purchasing approaches. So I think that was really great experience. And we'll come back to you with more questions when we get to our discussion section. So I'd like to move on now, if I could, to Professor Obi from Nigeria. We're going to hear experience of the mapping of the quite highly complex and decentralized system in Nigeria, but you were still able to pull out some very important lessons for us. So Professor Obi, we'd like to turn it over to you, and we'll bring you back then for the discussion.
All right, thank you very much.
Professor, we're not hearing you.
Yeah, who is sharing the slides? Okay,
So the Spark
thank
team
you.
is sharing. Can you see them okay? Excellent.
All right, yeah, okay. All right, thanks. We looked at many financing mechanisms in Nigeria, but for this talk, I'll look at two financing mechanisms and the issues of strategic purchasing within them. So the first one is GTR, which is general tax revenue. And then the second one was the finance mechanism was the National Health Insurance Scheme. And then within the GTR, general tax revenue, we picked a particular program. It was a free MCH, maternal and child health program called the Short MCH. And then in the National Health Insurance Scheme, we looked at the formal sector health insurance program, which is a social health insurance scheme that covers the public sector workers. So in the general tax revenue, well, the money comes from the federal government and the state government. And the purchasers are usually the federal or state governments through their ministries of health, different agencies and programs within the ministries of health. And then the providers in the general tax revenue are usually government-owned public health institutions. There's no provider purchaser split in general tax revenue. There's no contracting, but there's for the maternal and child health program, there's an explicit benefit package that covers high priority maternal and child health services. And then the payment for services were through line item budgets. Now, for the formal sector health insurance program, there's contribution from the employees and employers, which are pooled by the National Health Insurance Scheme. And then the purchasers are we have health maintenance organizations and the National Health Insurance Scheme itself. So depending on whether the primary, secondary, or tertiary services. So the HMOs usually purchase the primary and secondary services, and the National Health Insurance Scheme usually purchase tertiary services. And the providers are from accredited public and private facilities. And then the benefit package are quite explicit in the health insurance scheme for both inpatient and outpatient services at all levels. And the payment is for capitation for primary services, and then a fee of service for secondary and tertiary services. Now, the next slide, please. So the areas of progress. So for the the issues of strategic purchasing are now happening, like I mentioned before, within both the short MCH, which is from general tax revenue, and the formal sector health insurance program. So because of strategic purchasing, we've discovered there's an increased utilization of maternal health services. And then, in fact, because of, in order to make some progress with provision of services, more health workers were deployed. And then the health infrastructure were actually improved at primary health care levels so that, there'll be more efficient use of services because the money is now being targeted to provide a specific service for a vulnerable group. And then because of this efficient, and targeted and equitable use of the funds, we found that there's reduction in informal payment of user fees. So there's improved financial risk protection to the beneficiaries. And there was also improved incentives for performance, because there's also some incentives for the providers to provide the services, either to refer pregnant women to attend antenatal child health services, or for postnatal care services. And we also found that there's improved accountability, because the communities, through the World Development Committees, were also involved in managing the funds. Now, for the formal sector health insurance program, also improved the revenue available for participating facilities, and then who use the funds to improve on the quality of their services and actually provide some incentives to their health workers. And they also discovered that there was increased responsiveness. Beneficiaries were experiencing less delays and better quality of care than people who were not enrolled in the scheme. And then the scheme has also become more efficient, with saving lots of money, because they become purchase, using strategic purchasing and using very well defined benefit package. So this is what has happened within General Tax Revenue and National Health Insurance Scheme. So we've seen that because of strategic purchasing, some progress have been made. So, but I think in conclusion, there are still challenges. Moving from the traditional passive to strategic purchasing, but it's not in doubt that because where we have strategic purchasing, there's more efficiency and there's more equity and more accountability in deployment of services. But I think if we are to achieve UHC, we need to use strategic purchasing, because we can do a lot with available resources if we target them very well. If we purchase strategically, and then we can cover make an incremental move towards UHC with strategic purchasing, because we can use what available funds we have to achieve more health for available money. But I think it's important that a lot of awareness is raised, and capacity also developed among decision makers in the Ministry of Finance, not just health, and also the Ministry of Health, to apply strategic purchasing in resource allocation and in preparing both in annual budgets. I mean, this used to be done, but I think we need to really get that done, and therefore Ministry of Finance to use it as the basis of allocating resources for Ministry of Health, to make sure that all the resources that are going into the health sector are used efficiently and equitably to achieve targeted goals. This way, I think the health sector will be better. So I think this is where I conclude, and I'll say thank you very much, and I look forward to the question. Thank you.
Thank you very much, Professor Obia. I think that the experience in Nigeria also highlights some very important lessons for us. I think one is that we'll come back to through our discussion is the incremental nature of progress. Often we're hoping, we can make a big change in purchasing institutions or arrangements, and there'll be a big change in incentives and then outcomes. But in fact, progress really happens more incrementally. I think the other big lesson that I would like to draw out from your experience, and I think it's very relevant for a number of countries in sub-Saharan Africa, and that is aligning government free healthcare programs that are run out of the Ministries of Health with new national health insurance agencies and those purchasing approaches. I think what you shared showed that there is a lot that can be done within Ministries of Health and improving purchasing within that agency. And really you showed, I think, quite a lot of progress there. And so the countries that have either both or maybe are considering adding on a new health insurance agency, maybe to look at this experience and to ask, is it really necessary? Have we gotten all that we can out of our Ministry of Health purchasing arrangements? So we wanted to now open it up to questions and discussion, first from the audience, and then maybe the moderators will have a few questions to pose to our panelists. I don't see any questions coming in right now from the audience. Maybe I'll give a minute or two to have questions come in if anyone would like to pose them. But maybe just to open it up with the first question, and then I'll pass it to Nkechi for additional questions. But in both of these examples, we saw how incremental progress was made by both strengthening the purchasing functions within your particular schemes or arrangements, but also managing the external factors. And I know that all of that is both a technical and a political journey. So I wanted to ask maybe Elizabeth, starting with you, how did you navigate the technical policy priority, the technical ideas about what was best for a policy direction with some of the political challenges of actually making progress in that way? And then I'll ask the same question for Nigeria from Professor Obi. Elizabeth, do you have any thoughts on that from your experience?
Thank you. Like you've mentioned, one of the things that have been helpful in Uganda, we have working groups, technical working groups in the Ministry of Health that brings together development partners, it brings together NGOs, it brings together the government, and different policymakers. So often at these technical working groups, they're able to review data that comes in, from various forums. We have an annual health sector review. We have different surveys that happen in the country. And so these different reports point out the main challenges that we are facing as a country and what needs to be done to address that. So talking about the issue of zoning of donors, for example, you note that there are areas of the country that don't have certain services, and then you find that there are areas that have multiple donors. And so there's a discussion about what can we do to ensure that there's coverage all over the country. And so the different partners get to appreciate that we need to work with government to ensure that we provide services equitably. And that opens the door for negotiations that are more favorable towards ensuring that providers or go where there is need, or different funders go where there is need. It also opens the door for ensuring that policy documents, guidelines that are being used to deliver services are also utilizing the best knowledge that is available. And so if government needs to update, for example, its protocols that it's using, then often that is highlighted. So I would say these forums that provide such discussions enables that. We also often have inputs, for example, from universities, where universities are able to publish reports that shows where we are facing challenges in the country. And for example, work that has been done in the area of strategic purchasing is able to point out where the gaps are and what needs to be done. And so that makes the evidence available to all parties concerned. And that is also able to prepare a roadmap. And then maybe lastly, again, the Ministry of Health is also open to making changes. For instance, we now have a UHC roadmap that tries to highlight some of the reforms that we need to be able to undertake as a country progressively. And so all this sets the stage for the different partners to take the actions that are needed. But having said that, of course, there are certain things that are often a hard sell and a hard buy politically, and for some of those things, it takes a little more time to convince, especially the political arm, that these changes need to be made. Yeah, thank you.
Hi, Cheryl. This is Nimala. Sorry to interrupt you, but there are several questions posted in the Q&A box in the portal.
I'm not seeing those, so if someone could help me either to paste them into our chat. But just to finish with this one, I think just to highlight what you said, Elizabeth, this idea of having a process, a formalized process, a technical working group where stakeholders can come together on neutral territory, having then also the right data and information brought into that process and setting the stage for then fair negotiations. I thought those were very insightful lessons. Professor Obi, how do you in Nigeria navigate the technical and the political challenges to make progress on strategic purchasing?
Well, it's challenging, but what we found out it depends on the leadership. Leadership at the Ministry of Finance, especially at the budget office, and leadership within the Ministry of Health and the agencies, because of the decentralized nature. So, so it's when we had, let me give you an example. We had a Director General of Budget of the Federation who actually set up a system of using medium-term sector strategy to inform term sector strategies. Very explicit objectives were set. So if any item is not going to be that objective for the country, it doesn't get into the budget. So that aligned almost all the budgeting to become strategic. And then, but recently, I mean, when we developed the National Strategic Development Plan, it was also a system of making sure that things that will be country will be spending money on will be strategic towards achieving universal health coverage and other health related SDG targets. So that's what we have. So we don't have a central pool of like in Uganda, but within different programs or the ministries, there are technical groups at work to develop what should actually go into the budget. But I think, like I said, I think we need a lot of it goes beyond the Ministry of Health. I think it goes, as if you have a proper leadership in the Ministry of Finance that guides everything that happens and that provides guidelines, it helps. It helps a lot. Thank you.
Thank you so much for that. Again, emphasizing process, but also leadership and dialogue that goes beyond the health sector. And you raised the importance of the Ministry of Finance, which is so critical, a very critical stakeholder in these discussions. I'm going to ask Nkechi if you are able to see the questions coming in from the audience through the portal. Maybe I can hand it over to you. I'm not able to see them.
So Cheryl, and Nkechi might still be having technical difficulties to unmute herself. I'm happy to read out some of the questions if that would be helpful. It's also if you click the down arrow next to live Q&A on your portal window, you should be able to see some of the questions. But just to kind of keep things moving along, there was a question from Mexico about from a participant from Mexico about experiencing pushback on purchasing, whether you see that happening in any other countries. In Mexico, there's now an attempt to go back to supply side financing, and is that something that's emerging in other countries? There's also a question, I think, for the speaker from Uganda about what you see as the biggest challenge to mainstream donor-funded PBF into the government's way of purchasing, and are donors willing to move to direct facility financing? So maybe we can start with those two questions.
Yes, thank you, Nimala. Since we only have about 5 minutes left for this segment, maybe I'll just ask Professor Obi to answer the question about pushback, if there's any pushback and kind of more inertia towards the line item budgeting, and then the question for Elizabeth on mainstreaming performance-based financing, and then we'll try to wrap up. And please feel free to turn on your video, speakers. Thank you.
I mean, there's always a pushback by people who feel they are not benefiting from when things become strategic. But I think the important thing is to have clear guidelines, clear SOPs, and clear accountability mechanisms. And there's no policy change where you don't have losers, and they always have to push back. But I think with the consensus and involvement, of community level and accountability has also helped to lower or to neutralize a lot of the pushbacks. Thank you.
Thank you very much, Professor Obi. And Elizabeth, probably there's actually some similar issues related to mainstreaming PBF also, but interested to hear that experience in Uganda.
Okay, thank you. So the issues about the challenges of donor funding for PBF, I think one of them is really the sustainability. Because if you set up systems and put in place everything that is required to provide services using a performance-based approach, you're going to require to change a number of things, inform the community about what they're getting, inform providers about the change. And so if the funding suddenly gets cut, then you run into a lot of problems. So issues of sustainability with donor funding has been one of the challenges. And the other one is also the fact that, often the PBF programs at times focus on a small set of services. So the ones that have been implemented in Uganda, for example, have focused a lot on reproductive health services. And yet as a nation, you go beyond reproductive health. You have people with non-communicable diseases and so on and so forth. And so it gets difficult for you to ensure that your package of services is actually meeting the needs of the entire population. And then of course, maybe lastly, for you to be able to pay promptly using performance-based financing, you need to have a payment system that works efficiently within the country. And you'll find that, currently it's the public financial management payment system that is fully operational within the entire country. And so that requires that you change certain things if you were to have nationwide coverage based on a development partner funded budget. Because of the time restrictions, I think I'll just stop there. Yeah.
Thank you both very much. And I think since Nkechi was not able to rejoin, I will give a little announcement on her behalf. I think this idea of mainstreaming performance-based financing in the context of strategic purchasing, SPARK is really engaging in an activity to change that conversation a little bit, rather than the idea of mainstreaming this. Can the existing PBF programs that are in place be leveraged better for more holistic strategic purchasing in the countries? So please stay tuned for that discussion in the coming months. I want to just have a couple of wrap-up thoughts from what we've heard today. We really started the session trying to use this mapping tool to identify progress on strategic purchasing in our partner countries, and then to try to understand what enabled that. We did see some progress in three areas in terms of defining benefits packages for the populations. Contracting in both countries has improved. And I think that there is some movement toward provider autonomy, although that was less clear. And there's less pronounced progress on provider payment being more strategic and using monitoring to tie to action for purchasing decisions. So I think this is very consistent with the poll that Inka took at the beginning of the session. It's very consistent with what we see in countries, that it's easier to make some progress on benefits and contracting. And then when you get further along in terms of payment and monitoring and tying decisions to information, it's more challenging to make progress. I think we heard a little bit about some of the external environment and these enabling conditions that are really important, harmonizing across different purchasing schemes, harmonizing between the government funds and donors, the very, very important role that provider autonomy plays in making progress, and the public financial management system, of course, needing to align. So I think those are helping us to think ahead. what are the conditions to be in place, but then the actual process of making progress, needing to bring the right stakeholders together, including providers, purchasers, ministries of finance, and others, into a well-organized, neutral process, and bringing the right information and data into that process, and setting the stage for good negotiation to really make sure that you can get past some of the interests and some of those who see that they might be losing if purchasing is more strategic. So a big thank you to our panelists. I apologize to those of you who posed questions that we didn't get to. Hopefully throughout the session, they will be answered. And with that, Nimala, I'd like to pass it over to you to continue with your session. Thank you.
Thanks, Cheryl, and thanks for that great discussion. Sorry, Nkechi, about the technical difficulties. I'm hoping you are able to rejoin before too long. And so we'll be moving over to the next segment of this morning's program. We started the conversation today with Inka providing a definition of strategic health purchasing, and then we had this great, rich discussion about a broad framework for understanding all the functional capacities needed for strategic purchasing. And now in this segment, we're going to dig more deeply into what strategic purchasing means for specific high priority health areas, using reproductive health services as an example. And indeed, this is the example we're using for this discussion, but there are obviously conversations also happening about strategic purchasing for immunization or HIV or TB, where many of the themes that we expect to discuss in this session apply equally to those areas as well. And so it's worth asking, what does it mean to talk about strategic purchasing for reproductive health services? Are we talking about a standalone approach just for reproductive health? Is there something new when we say strategic purchasing for family planning or MNCH? Is this a new kind of beast? And so I want to offer some reflections on that question to frame this discussion, and then I'll be introducing the speakers and the discussant, and we'll be moving along rapidly to their presentations. Sarah, if you could go to the next slide. My name is Nimala. I should have said that before, I suspect. And I work on a project called Strategic Purchasing for Primary Healthcare that's funded by the Bill and Melinda Gates Foundation. And in 5 countries, 3 in Africa and 2 in Asia, we're exploring this exact question, strategic purchasing for primary healthcare. And within that, we're focusing on family planning and MNCH. And so I wanted to offer some reflections based on the work that we're doing in these 5 countries to really get at this question of what does strategic purchasing for FP and MNCH means. And so when we look at these 5 countries, there's a huge variation we see in the purchasing landscape across these 5. And broadly speaking, in the 2 Asian countries, we have large national health insurance schemes, purchasing services from both public and private providers, existing alongside other purchasers like a National Ministry of Health and subnational governments. And contrast that with the 3 African countries where bulk of public resources are still flowing through a national health service or an integrated delivery model, but there are payment methods layered over that, going back to what Inka said, PBF payments, the gratuité or user fee reimbursement approach in Burkina, and a similar approach in Kenya. And so it's a very complex landscape in these 3 countries, and discussions about introducing a national health insurance scheme. And so when we look at these 5 countries, what concretely strategic purchasing for FP and MNCH ends up meaning is understanding how these services are currently being purchased and how that can be improved. And as these countries are talking about further reforms for universal health coverage, what does it mean for these specific health areas? And Sarah, if you could go to the next slide. In my mind, it boils down to 2 things. One, recognizing that in most countries there are multiple purchasers, and understanding the dynamics for any given health service area involves looking at the institutional arrangements for purchasing between national agencies, local governments, and national health insurers. Who pays for what? And FP is a great example of this, where commodities are being purchased centrally and subsidized, while by a Ministry of Health or a separate agency, while local governments are paying for salaries of health workers, etc. And then you have an added on payment either through a gratuite type of user fee reimbursement scheme or a PBF method to pay for the service. And so it's a complicated landscape, and understanding whether those incentives are aligned is a key part of this discussion. It also involves asking some of the same types of questions that we were asking at the system level about what services are covered, who are the providers that we're engaging with, how are those providers being paid, how are they being contracted and paid, but now looking at it within the context of FP or MNCH. And here, the example of private midwives from both Philippines and Indonesia is a great one, where many of these midwives are providing a lot of the FP and MNCH services, but are not participating in the National Health Insurance Scheme. And we'll be indeed hearing more from our speaker shortly about this particular question. And so bottom line, when we dig into the dynamics, we see for a particular service area, we see the need for more nuanced understanding of the benefit package, about the right mix of providers and the provider payment methods. And so indeed, the two presenters today, the two country examples we're going to be hearing about, will be reflecting many of these themes and many of these nuances for reproductive health. If we could go to the next slide. So without much further ado, let me quickly introduce our two country speakers. So we're going to be hearing from Burkina Faso, from Dr. Pierre Yamiogo, who's the Technical Secretary for Universal Health Coverage within the Ministry of Health in Burkina Faso. In that role, he directs national strategies and reforms for Burkina Faso's journey towards universal health coverage. And Dr. Yamiogo is a medical doctor and a public health expert who's been coordinating the Gratuité program since 2016, and that's a user fee reimbursement program for MNCH and FP services, and he's going to be sharing learnings from that experience with us. Next, we'll be hearing from Dr. Prastuti Sawando, also known as Ibu Beki, from Indonesia. She's the country director for ThinkWell in Indonesia and leads the strategic purchasing for primary healthcare project there. She's also on the faculty at the University of Indonesia School of Public Health. She served as the lead of Indonesia's Social Health Insurance Policy Working Group and the board of the National Health Insurance Agency, BPJSK. And we have the great pleasure of having a discussant for this session, Dr. Ellen van der Poel, who leads GFF, so the Global Financing Facilities Health Financing Workstream, and she supports GFF partner countries to develop and implement strategies to increase domestic resources for health and also improve efficiency of their health spending. Before joining GFF, she was an associate professor of health economics at Erasmus University, Rotterdam. So those are the wonderful speakers we're going to be hearing from. So without much taking up any more time, I'd like to invite Dr. Yamiogo to share some insights from Burkina Faso. I encourage you all to continue posting your questions in the chat. Thanks. Over to you, Dr. Yamiogo.
Thank you, Nimala. Good evening, everyone. I would like to thank all the organizers and NGO ThinkWell for the work that I take part to this important session to share the experience of Burkina Faso in implementing a model of static processing with gratuity user fees for healthcare for under 5 and women. And the main of this presentation is how tailoring processing for LMMCH services we were developing in Burkina Faso. And next slide, please. Since 2016, the government of the Burkina Faso adopted a national free healthcare. We know it gratuity scheme for women and under 5-year-olds. The scheme seeks to remove the financial barrier and to improve access of health services as part of the country's to support progress for universal health coverage. So I want to note that the prior of the scheme is to facilitate the operating costs of the health facility, and out of payment, the gratuity was established to replace out of payment with payment by the government. Free services for women and children. We define a package for maternal, newborn, and child health service free of charge. And the government and oversight, Ministry of Health is the main actor which manage the scheme through my technical secretary in charge of health coverage. We have an innovative system because we contracted with NGOs to act as the control mechanism for the monitoring of the scheme. Fund is the budget of the government. We contract directly with national and with non-governmental organizations. Next slide. Benefit package for the two beneficiaries. We have an iterative process evolving over time. So at the beginning, we define a comprehensive benefit package to address to the health needs of Burkina Faso. And after we are progressively additional services, and the last services we add in the package is the family planning services. And the picture under, we cover in this gratuity package services for children defined by IMC protocol, primary health care, and antenatal care and postnatal care, delivery emergencies, long and short acting contraceptive method, and treatment for obstetric fistula. We added screening for precancerous services, cervical lasers, and breast cancer. So all each care we consider all the services such as consultation, cost of medicine, cost of exams, cost of medical evacuation, and cost of hospitalization. Next slide. We to have the luck to have the success of this scheme, we changed our payment method, learning but during the pilot implementation from the of the free healthcare. So we defined after negotiation with my Ministry of Finance to to create a special account in each district and each hospital, and we define some fund for healthcare preposition based on its historical quarterly into district and hospital gratuity. This is a big innovation because we don't have to reimburse the bill of the cost of the care, but we define this payment method to avoid the problem of the problem at the health facilities. And 2 years after the starting of the scheme, we changed the method of payment, and we define to earmark the funds for the central medicine store directly to from 60 to 18% of the preposition fund directly to give to the central medicine store. And control, the control, we contracted directly with now 7 non-governmental organizations to measure and to calculation the subsequent payment. And the health system, we developed a platform on the DHS2. The name is eGratuité platform for the management of the scheme. It is accessible for data entry, access, and analyzed by health information officer from all region, district, and hospital. Next slide. After 5 years implementing this scheme in the all region of the country, we can say that gratuity policy is a significant effort to remove financial barriers for the key health services, and so to improve health care access in one of the world's poor countries. Now, to date, gratuity appears to have achieved in primary goals of improve access to service and reduce of payment. I want to share with you 2 main indicators. The first indicator is you see the progression of women making 4 antenatal care visits in public sector before gratuity and after gratuity. So we have after gratuity, we have more than women who use a health facility. It's the same progression for the children under 5 in public sector before gratuity and after the gratuity. The main challenge are now we in the process of implementation. We have the approach of learning by doing, and we are now the technical assistance of ThinkWell and Spark to move progressively towards strong strategic purchasing model. So the consultant and are now in Burkina, and we are using the framework to assess the gratuity policy and to improve a very strategic purchasing using gratuity. And the second challenge, the process evolve as needed some reform. So human resource, commodity procurement, and payment methods. Thank you very well. I think that is the last slide.
Thank you.
Thank you. Back Kawusugo.
Thank you so much, Dr. Yamiogo. Great way to get this discussion going. I think, you brought up some of the themes that we heard in the previous session about incremental change and building off of a small package and adding more services to it. And then the second issue about the flow of funds and how these funds reach the front lines and how the providers are using those funds is also echoes some of the discussions in the live chat about direct facility financing. So thanks so much. And to keep us moving, let me invite Ibu Beki to share some ongoing work in Indonesia and some lessons learned from there. Over to you, Ibu Beki.
Thank you. Thank you, Nimala, for the introduction. Very good morning, good afternoon, and good evening for everybody. It's my pleasure to have the opportunity to present and share our experience on the work of strategic purchasing of maternal and newborn in Indonesia. This project is actually a joint collaboration between Result for Development, R4D, and USAID Health Financing Activities, and also the strategic purchasing for primary healthcare, Tingwell. The project has currently finished the design stage, and we had originally planned rolling out the implementation on the 2020, but due to COVID, it's currently rescheduled for this year. Next slide, please. Thank you. So Indonesia has made achievement in improving many of its health indicators, including some indicators of health and well-being, such as extended life expectancy rate. Unfortunately, Indonesia has not reached the SDGs goal on maternal mortality rate. The maternal mortality rate in Indonesia remain high. In 2017, 310 deaths per 100,000 live birth, so still 3 times as much as the SDGs target. So this is despite the fact that a majority of the births are assisted by skilled birth attendants, but mostly the skilled birth attendants are not in the network. So as a background, before going in detail in the MNH, please allow me to give a glance of government policy toward universal health coverage. JKN, we call it Universal Health Coverage Initiation. Purchasing agencies was established in 2014 and have now coverage about 84% of Indonesian population. The single pool purchasers integrate several health insurance schemes for the poor, employee, and civil servants in one scheme called JKN, the purchasing agencies. So JKN provides a quite comprehensive benefit package that purchase services from public and also private providers for outpatient and inpatient care. The revenues are based on contributions, with the government providing full subsidies for the poor and near poor. In respect to the MNH program, midwives, private midwives, play a big role in the society. 60% of all births are assisted, as you can see in the graph, assisted by private midwives practitioners. They are also family planning. Private midwives also play quite a big role, 41%. And after 7 years of implementation of JKN, we can still see that JKN purchasing power is not yet optimal. So we are in the dire need of better strategy to increase access and incentivize better quality of MNH services. So the evidence shows that utilization of JKN members for MNH services remain low because the payment are not properly incentivized toward the primary healthcare services. As you can see in the top chart, the poor is still prefer to give birth at the home and private GP midwives facilities, and their main source is mostly out-of-pocket. Next slide, please. Having that background, this project has a specific objective to strengthening the JKN purchasing power in MNH services through strategic health purchasing. So in more specific, this project aims to link MNH services quality and payment across delivery networks. So we intend to do this by setting effective contractual agreement with a strong payment mechanism and incentive will attract private, hopefully will attract private midwives in the network. Okay, so to give you a quick overview of what we have done, in the bottom part, actually the initiation started at the mid-2017 by reviewing JKN purchasing regulations. So by that time, we already know what is the advantage and the disadvantage and what need to be improved. And in the 2018, actually, the government led by the Ministry of Health formed technical working groups, and it's quite effective, involving many of the key stakeholders. And then in the 2019, we collect data by fact-checking to gather all the data and then also combine with secondary data. And then in the 2020, we constructed technical design, estimated budget impact, and engaging with the local government. We had planned to roll out, but like I said earlier, unfortunately, it will delay, but hopefully it will be scheduled to begin the pilot this year. Next slide, please. Yeah. This diagram summarizes the output of technical design of the strategic purchasing for the MNH. It is a combination of Ministry of Health new guidelines to improve the quality, which we can see in the yellow part on the left side. And then the right side, the blue in the right part, is actually a recommendation from the technical working group. So Ministry of Health was at the state of designing a new guidelines to improve quality by adding 2 times antenatal care, visit assisted by general practitioners, so from 4 to become 6, and then delivery that is assisted by at least 2 skilled health personnel, so it has to be 4 hands at least, and then and in addition, 1 additional postnatal care, because we know that many of the death, maternal death, is at the postnatal period. And then on the right side, in our design to improve the strategic health purchasing, in the blue part is developing the direct contract arrangement between purchasing agencies and the providers, and then also developing a new provider payment mechanism. We reviewed that the previous provider payment mechanism was not too effective, not too attractive to the private midwives. So, and then there are also a network coordinators that oversee the private midwives activities, including the quality. Next slide, please. Yeah. So in this next slide is a lesson learned. Our team learned several things in designing this pilot project that would like to share with you. The first one is that many key stakeholders, as you can see, is involved in these charts. Perhaps one of the most important and challenging is to get the buy-in from the purchasing agencies. We call it BPJS Health in the purple blocks, since it will require them to change the payment mechanism and also adjust the tariff. So there is quite a challenge and intense discussion with them. Other stakeholders' commitment is crucial also, and because there are many policy dimensions, two of the most important is they have to increase the MNS access and quality and strengthening the financing of service delivery networks. This was quite a long process requiring intensive iterative discussion, especially to get a buy-in process at the central policy level. The second one is BPJS and providers relationship. Purchasing agencies with the providers relationship, we understood that both have different motivation and preference. So strategic health purchasing design must balance, the interest of these two providers as well as the value of money for the purchasers. We're also interesting dynamic in coordination and adoption process, beginning in preparing the technical design and then forming the algorithm and then communicating to the stakeholders and adapting it in the whole process in regards to the feedbacks. So we anticipate that providers will need sufficient time and proper guidance to adapt with the strategic health purchasing. Lastly, another important point is public-private partnership. Strategic health purchasing was designed to strengthening both public and private primary healthcare and to encourage stronger partnership between public and private, especially in the screening examination. So case in point, when Puskesmas or public private PHC lack of resources to conduct screening, then the private sector must be willing to step in to provide that. So next slide is, we are very happy, this is my last slide, we are very happy with the progress that we have made since 2017. Now, that the framework and the buy-in that we have carefully built together will serve a strong foundation of our coming work. This pilot has addressed three main elements that has been mentioned several times is what level of quality that we want to purchase and from a qualified providers and under incentivized payment mechanism. Our team is very anxious to continue to the next phase of this pilot and begin the implementation this year. So that's conclude my presentation. Thank you so much. Back to you, Nimala.
Thanks, Ibu, for that great thought-provoking presentation. It certainly underscores the importance of a process that's inclusive and participatory to bring various stakeholders to the table. And it, I think, speaks to some of the questions as well about pushback and, how do you create buy-in for a complex reform of this kind. I also really liked the emphasis on this not just being about payments, but about thinking more broadly about different kinds of providers, the quality of the services that they can offer, and how we bring them into the scheme and use the purchasing power of the scheme to influence their behavior. So thanks again for that great presentation. So let me now invite Ellen, our discussant, to offer some reflections, pose some questions, and get us started in the Q&A. Over to you, Ellen.
Thank you, Nimala. Thank you all for both inviting me to this session, to all the speakers and everyone joining. I'll be very brief as I think there's quite some questions from the audience. But one general reflection when listening to the speakers in this entire session is that I think it's really important that we clarify when we talk about this topic that we want to avoid any fragmentation around diseases or specific population groups when we talk about strategic purchasing. I think it's important to recognize that countries, governments really prioritize first a set of services, taking into account the budget they have and the cost effectiveness, in a way to maximize both the health gains and take into account equity considerations. So within that context, I think maternal and childcare, vaccinations, those type of indicators that we talked about in today's session are always part of such a prioritized package because they are among the most cost-effective services. But it seems evident, but I think it's important to really clarify this and stress this, that strategic purchasing is a more holistic reform, and we only basically look at specific diseases or services once that package has been developed. Also want to clarify this is really the way that within the GFF we aim to support this agenda and to avoid any verticalization of this discussion. So given that, strategic purchasing then really becomes a discussion around how you best compensate providers to provide these specific services. And that's indeed where disease-specific issues come in. I think it's fairly obvious that for most of the maternal and child health-related services, there's no reason to want to ration care. So the provider payment mechanisms are really sort of meant to increase the volume of the services to be provided. And I think this is where building or linking to the performance-based financing schemes can be interesting because the fee-for-service model that is implemented there is really very appropriate for preventive care, of which you can't really do too much of. So I would really like also to invite a Burkina speaker to talk a bit about how this integration, assuming that the scheme he talked about with the gratuité builds on the PBF experience, how that link was made. And we heard a bit of that from the Uganda speaker too. And to Cheryl's point, I think we talk a lot about the PBF being a possible stepping stone for a larger strategic purchasing discussion, but we don't have that many countries that have actually managed to transition from something donor-driven to something more government-owned. So it would really be helpful to hear about that. Now, obviously, there are a few issues with over-provision for C-sections and those sort of things. But I think those are fairly, usually we really want to incentivize more services. I think it's interesting here from the Indonesia example where they sort of moved more from the opposite direction from a capitation-based system that did not perhaps incentivize enough utilization to something that's now more case-based. And I was just wondering, I wanted to invite the speaker to talk a bit about how they, well, I understand now the pilot still needs to happen, but how that discussion, how she sees that moving in the future. Is there going to be a move to more performance-based payments, top-ups, things like that? Or is it really politically still quite challenging? And then the third service that we sort of started this discussion with is family planning services. And that's quite tricky, I think, because there the preferred treatment really depends on patient preferences. So it's hard to really incentivize. And there's a history, of course, of coercive practices. There's also some perverse incentives between, on the one hand, many schemes using capitation for primary care and then case-based payments for delivery. So you have the incentives not aligned. And we didn't really talk much about it in this session, but I was just wondering to which extent two schemes that were presented, how they specifically look at the provision of family planning commodities. So that's on the more technical part on how to pay for these specific services. But having said that, I also think we need to recognize that in many cases, the bulk of the resources being spent on primary healthcare services still flow through an input-based mechanism. And these schemes that were presented also today often reflect only a minor part of the resources going to facilities. So given that, I think we need to be careful to not focus too much on the specific provider payment mechanism when we talk about strategic purchasing, because it does risk to become quickly an academic exercise and not a very practical one, given that a lot of the resources are in salaries, supplies, these sort of things. So I wonder to which extent, we'll also invite other speakers to reflect on this. I wonder to which extent we should be clear that strategic purchasing is not only about financial incentives to providers, but also really requires looking at salaries, supply chains, and even the way, in this case, women and children access services, and try to make sure that when facilities have sufficient resources, that they have the right support, training, staff to provide these services beyond just looking at the financial incentive. And then one more topic that we didn't talk much about today, but I thought would be useful to flag, is the issues in relation to data management and fragmentation in data management. I think a lot of the schemes, also the ones we heard about today, sort of cater to a specific population group. It's usually not 100% of the population. And because of the provided payment mechanism, they tend to set up systems to then, for facilities to submit claims or to track whether services are being provided to that specific population group. And that sort of starts to coexist with the regular HMIS schemes that track services delivered to the entire or the rest of the population. And that sort of can create challenges when you want to expand coverage. So I'm sort of thinking it's really important with these sort of schemes to make sure that the information systems that are built around those are really very early on integrated with the broader HMIS, so that you can indeed you can monitor service delivery and utilization for a population as a whole, and not only for these specific groups that benefit from a particular scheme. And then the last point I wanted to end with, it's an easy point to make. I think everyone realizes that, but still I wanted to flag it, is that especially in relation to maternal and child healthcare, I think purchasing for quality rather than quantity becomes increasingly important, because we see utilization go up in a lot of countries without the accompanied health impacts often. And I think that again, just relying on financial incentives will provide some solution, but quite limited. I think there's a much broader sort of set of tools to look at. So when we discuss when we're going to move to more purchasing of quality of care rather than quantity of care. So again, just a topic for a broader discussion, but perhaps also useful to hear how the two countries are thinking about this issue. So let me stop here. Thanks again for inviting me, and interesting to hear the participants and speakers' opinions on these issues. Thank you.
Thanks so much, Ellen. Those are great questions to get us started. And I'll also be drawing on some of the questions in the portal. So Ebubeki and Dr. Yamiogo, some questions for both of you. One around PBF and how to integrate. Perhaps this is actually a question for you, Dr. Yamiogo, about the gratuité policy versus ongoing PBF payments, and I think a newly planned health insurance scheme, and this concern that both Ellen and some of our some of the commentators on the live chat have expressed about fragmentation, and certainly this was a comment Cheryl made earlier. How is Burkina thinking about greater coherence between these different approaches? Ebubeki, a question to you about payments, and specifically this issue of wanting to improve, for BPJSK, this concern about rising costs when people access services at higher level facilities, and wanting to bring in primary healthcare providers and midwives, and how to balance that with a concern about quality. So I'm trying to merge a couple of different themes that Ellen touched on into one question to you, Ebubeki. And then to both of you, a question about family planning and what you're seeing in your two different contexts about family planning, how it's positioned within these schemes, and what are some of the dynamics around family planning. And I think final question, this is from the live chat. Many of these schemes, like JKN and Gratuité, do require, at least in the JKN instance, it requires membership. And I believe in Burkina, there's also discussion about introducing a membership card for the Gratuité policy. Are there concerns about whether everyone will have access to these services that are currently a universal entitlement once they get included into more tailored schemes. And so this is not just about MNCH or FP, but also TB and HIV. That was the question posed in the discussion. So there's a lot here. Over to you, Pierre first, and then Ibubeki.
Thank you, Nimala, and everyone. The first question, my apology for my English level. I will try to speak slowly. So PBF in Burkina Faso, we decided to merge PBVS approach with gratuity approach. And now we are building a model system to have a strong strategic purchasing with Thinkwell and Spark technical assistance. So since 2017, we stopped to implement PBVF model, and we are reflecting to merge the two approach to be very efficiency because we don't want to have a fragmentation system in the same health system. I can assure all the participants that we are on the good way, and the next 6 months we can present the new model of strategic positioning, include essential functions of PBF, not a PBF model that we implemented during 4 years. The second question is about family planning. Family planning is a services which we include in the package. I explained that we start at the beginning without family planning care. And since 2 years, we have family planning in the package, and we held a meeting 2 months ago to identify breast services cancer, to see other package to include in the free healthcare. Government finance about around 15.5 billion per year, and it's a very important decision that we make. The last question I understood is about register of the beneficiaries. It's a reflection we are doing now to implement a new model to avoid fraud. We noted that some beneficiaries go in many health facilities to have medicine and to give, and after to give the medicine to other person. So it's a very complex question. I'm okay with it can do a problem with access if we implement this method, but we are in the reflect to build a good register system and to avoid that we have fraud in the to access to the free care. I don't know if there is something to.
Thank you so much.
Okay.
Thank you so much, Pierre. I know there's so much more to be said on any one of these questions, and we're quickly running out of time. So let me quickly turn to Ibubeki. Ibubeki, thoughts on the payment question and on the family planning question.
Yeah, thank you. Thank you for the question. Thank you for the feedbacks, Dr. Allen. So I would like to start responding to a question about the out-of-pocket. Actually, for the maternal neonatal health, the purchasing agency, BPJSK, not paying by capitations, but this is paying by fee for service. The tariff is quite low. When we did the facts finding, we know that we try to identify what is the main reason, the private midwives not joining the networks. From estimating from 5 million deliveries, 5 million deliveries per year, it's only 1.2 deliveries under the JKN members. So the government is actually trying to think why the coverage is 84%, but not too many people are using that. And we're trying to gather the data, and we understand what is the reason. And from the survey that we also analyzed, we understand that actually the private midwives still play a major role in the delivery, as well as they are the community. I mean, the pregnant women is very trust the private midwives, but we also know that the quality served by the private midwives is quite huge variation. So and then the contractual, one of the other reason is the contractual agreement was not really clear, and it's not benefiting the private midwives to join. So from that, all the facts that we know, so we are trying to say that, MNH is a national priority, so we have to seriously work in that. And we also realize that after 7 years of implementation of social health insurance, we are not really significantly reduce the maternity rate. And we found out the death of maternal death is shifted from the primary care to the hospital, and it's kind of late referral, because private midwives try to keep until the last minute, and so when it's sent to the hospital, it's already at the late condition, and so the cost of delivery is quite high, and many C-section also, that's another issue. So based on that, we are trying to think that this is the opportunity to improve the payment mechanism by strategic health purchasing. Of course, this is not an easy thing, so we are still need to negotiate with the BPJSK, with the purchasing agencies, but Ministry of Health already confirmed that we need to apply this. We changed from the fee for service to bundle payment, so it more reducing bureaucracy, administrative, and it's more attractive. And we create networks that can handle some bureaucracy things, so the private midwives do not have any additional burden for administrators. And with related to the performance-based financing, I think the BPJSK, the purchasing agencies, already apply for purchasing for performance-based financing in the primary healthcare, with asking the primary healthcare to fulfill a criteria that they agree, and when they don't know, they review it every 3 months, and when they not fulfill the criteria, then it will impact on the amount of capitation for the following period. So it's true that it may not be more too effective, but I think it's already started, and I think as time goes on, they are trying to improve the implementation.
Ibu, I might have, I'm so sorry, but I'm going to have to interrupt you.
Oh, yeah, okay.
We've come to time, and
thank you.
Thanks so much. I fully appreciate we've just barely scratched the surface of a lot of really, really interesting issues. And I just want to reassure folks we can plan to continue to have some of these discussions in subsequent webinars. So please stay tuned for that. And let me hand things back over to Inka as we've really hit our 2-hour mark to wrap up and offer some final thoughts.
Great. Well, thank you so much for these really fantastic presentations and this interesting discussion among the speakers together with you and your questions. Bear with us maybe a few more minutes. We are trying to wrap up. We had 2 final poll questions, and I see already that responses have come in for the 4th one, which is what needs to happen in your country to make purchasing more strategic. I'll come to that to speak in a minute. And then the final one, what are important research questions related to purchasing? Now, in the chat, there are so many really interesting topics and questions that you raised. I am not in the position to actually bring them all together in this short time, but just to mention a few. I think an important research question is, and policy questions is really about how to align or how to strengthen the alignment between purchasing and other areas, how to leverage PBF for strategic purchasing, how to strengthen the data-drivenness in this process of moving towards strategic purchasing. So lots of interesting questions, and we will have to go through them in more detail. And, as Nimala just said, sort of, bring that back in subsequent webinars. So let me try to wrap up with 3 or 4 key messages. And I'll take it actually from this poll question number 4, what needs to happen in your country to make purchasing more strategic? I think this has come out in the country presentations, and it's showing here. So you have put better coordination and collaboration among stakeholders, purchasers, providers, etc., as one of the key aspects, as well as stronger leadership of the ministry as a key steward. I think this has come out in all of the country presentations. So really this need for a neutral platform, for a process that is well set up, institutionalized, where all stakeholders come in, and bringing in a technical as well as a political viewpoint right from the beginning when it comes to setting up, designing, purchasing reforms. And I think that also will help to deal with the resistances and with the pushbacks that may come from specific stakeholders. It's also about bringing in the right data. The other important point that I'm taking is this issue of the incremental nature of moving towards strategic purchasing. There aren't big bang reforms, and the effects won't be big bang either. So it's really about this gradual process. Moving towards strategic purchasing is really a combination of several policy instruments. They may be, rather of technical nature in a lot of cases, not require sort of big bang legal decisions at parliamentary level. So it's this gradual process that it's important. And what I also quite liked was this talk about, I think we heard specifically in Uganda, but also it came out in the other presentations, this guided autonomy. I think that's a nice concept. So one important aspect for strategic purchasing to be realized is that providers actually have some more financial and managerial autonomy, but at the same time that needs to be in line with their accountability and with their capacity to be accountable. So guided autonomy needs to be combined with support in planning, and has to also come along with the respective funds. And maybe the second last point is on the importance to align strategic purchasing reforms with other health financing functions, and even beyond that with other health systems aspects. I think Cheryl has put it as external factors. So just referring to that discussion, there needs to be harmonization across purchases. We need a harmonized purchasing system. So really that brings us back to the importance of effective governance arrangements, plus the alignment with public financial management, with procurement, with the adaptation that have to take place at the provider level, as well as alignment with donor funding, with donor-supported schemes, if I may say so, in quotation mark, so as to avoid duplication and efficiency. Again, this has been an issue coming out in several of the presentations. And last not least, Ellen has really put it nicely, and I just want to reiterate it. As we think about specific high priority health interventions, and we need to have a differentiated understanding of, the dynamics and the specifics of these services, we still need to think of the purchasing system in a holistic way to avoid fragmentation and to not get back into the whole verticalization discussion. Well, we have to have that discussion, but to sort of get away from the verticalization. So just looking at the watch, yes, I think I should stop. It's 5 minutes after 6 o'clock, at least Geneva time. I thank you very much for your participation, for this brilliant exchange in the chat with many interesting questions, comments, and also a big thank you to the speakers. Thank you very much. All the best to you. And until the next time for the next webinar, Strategic Purchasing. All the best. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye. Bye.
Becky, big thank you to you for staying up till midnight.
Yeah, this is past midnight in Jakarta, Indonesia.
Please go get some rest. Thank you so
Okay,
much.
bye-bye. Thank you.
Bye-bye.